Morning, morning everyone. Looks as if everything's good. My end. Hi Rahul. Hi Becky. Becky, the STA thing looked really good on the weekend. Looked really good. I'm glad it went well. Right, let's get going. Morning, David. Yeah, very good. Thank you. Right then, so this is where we left off last time. We were looking at the retinacular, so looking at the connective tissue around the wrist and the hand, and we're going to build on that a little bit because there's a few more bits to do, and then we'll go into the muscles, and there are lots of muscles. So we'll do the wrist first of all, and then we'll move into the hand. And yeah, just to make it a bit more kind of broken up and easier to digest because there's lots going on. Hi Tris, good to see you in as well. Right, let's have a look at this then. So yeah, this is where we were. So we looked at the flexor and the well, we just looked at the flexor retinacular. I don't think we got to the extensor retinacular yet, so we'll just do a quick recap on that. And if you remember, we were talking about the retinacular as being like a pair of skinny jeans. So if you were wearing flares on your arms, then they weren't tight fitting, which they shouldn't be, then the tendons would travel to their destination, but they wouldn't be wrapped in anything to keep it close to the bones and the joints. So the tendons would literally like be from there to there. Okay, but obviously we've got all this connective tissue that keeps the tendons close to the bones, so that they can generate more force. And we were talking specifically about some of the muscles in the fingers, which we'll have a look at today. Hopefully we should get to those today. And you can hang from just your fingertips. So, and they're only very small muscles, really, when you think about it, that are involved in that particular activity, being able to do that. So the way that they can generate that amount of force is because of all the connective tissue that they have to pass through to get to the fingertips. So the connective tissue gives it improves the efficiency of those muscles. So that's where we were. So let's have a look at the flexor retinacular. Let's get rid of that one. Here we go. So the flexor retinacular is also where the when we look at the carpal tunnel, just get rid of that. There we go. So yeah, we had a look at this last week. So we've got the carpal tunnel, which is the flexor retinacular, attaching to bones in the hand. So you've got the roof here. We've got the trapezium and scaphoid on this side, and then the hamate and pisiform on the other side, so little finger side. And the retinacular fits over the gap in between. but they attach onto those bones. So we've got a couple of mini tunnels, which we'll talk about later as we start adding more structures in. So that one's specifically for flexor carpi radialis. We'll have a look at that in a second. And then we've got a little tunnel here, which is, just pause that there. So that this is significant. And again, we did cover this the last time, but always worth going over it again. So this tunnel is for the ulnar artery and the ulnar nerve, which supplies this side of your hand. So these two fingers and a little bit of that one. And it's the reason why if you have got a carpal tunnel, these two fingers aren't affected, because the nerve passes over the tunnel. Yeah, so the tunnel's here, and then the nerve will go through this little hole here. There is another little structure that it passes through, so that the hook of the hamate, which we had a look at when we were looking at the bones of the wrist, the ulnar nerve passes underneath the hook of the hamate as well. And sometimes it can get compressed there, especially in cyclists. I don't know whether you remember me saying, but if you road bike, mainly road bike because of the position of the hands, then that can compress the ulnar nerve and then make these two fingers go a bit numb. Okay, so but that's why, because of the structures. Morning, Steph. Morning, Penny. Yeah, so the median nerve goes underneath here, and the ulnar nerve through there. So that's why we get the different symptoms. Just finish this bit off. Oh, that was it. Perfect timing. So that's your flexor retinacular, which was this one here. I'm going to have a look at the extensor retinacular now. I think I've got a video on that. It might be in the next section. Let's have a look. Oh no, it is here. Yeah, perfect. Okay, let's have a look at this one. So obviously on the opposite side of the wrist, we've got all of the extensor tendons that come down this way, which extend the fingers. And we've got a retinacular here as well. And there it is. So it kind of wraps around the whole wrist. The carpal tunnel does. So it's not just that area there. It is continuous all the way around. And if I just pause that there, what you can see there is also a cut section. Yeah, so what the retinacular is all over the arm. So it's the fascia that layer of fascia that covers the whole arm. But that particular area there, and then the carpal tunnel here, is thickened. Okay, so and that's the reason why it's significant, and why in all the textbooks you'll just see that bit highlighted and everything else is gone. It's because that area is of anatomical significance. But basically that extensor retinacular there and the carpal tunnel that you saw before, if you saw a whole hand just with the skin taken off, you'd be able to make out the carpal tunnel, but it will be continuous with the whole forearm and then going up into the upper arm as well. So it's just a thickening of the fascia, and we'll see that in the fingers specifically. Just go back and watch that again. So there's the retinacular here. So this is the skinny jeans for your wrist, and all of the extensor tendons travel underneath there. So you've got the radius on this side, on the thumb side, ulnar here on the little finger side. So you've got the ulnar styloid around there, which is that kind of lumpy bit just there. So we've got several tunnels underneath here, and we're going to have a look at those when we get into the muscles. But to just go past there, so we've got, look at that, they're separated out. So the extensors have got their own tunnels, and they've got specific areas that they go to. Here you go, you can see it there. Look, you can see the pathway. So all the extensors, the fingers, the thumb, the wrist, all pass underneath there. Just go back again, see that again. So they've each got their own little tunnel, and that will be significant later. So if you do any sonography or have a look at any imaging and you're scanning this part of the wrist, you can identify every single one of the tendons depending on which compartment they're in. Okay, so you can use the anatomical landmarks. That is quite easy to do that. And one of them is we were talking about this the other day. We were teaching face to face the elbow, wrist, and hand, and we've got the radial styloid just on this side, so whether the thumb side down to the radius. And then if you come across the radius and kind of move side to side, you'll feel a bony lump there. Okay, so there's like a raised ridge on the radius. It's called Lister's tubercle. And Lister's is important because it's a dividing bony landmark for some of those tunnels. Okay, so we've got some tunnels to the thumb side of Lister's, some tunnels to the little finger side of Lister's, and you can see everything is spaced out. And then using Lister's as a specific landmark, we can work out what's what. Okay, so it's quite useful knowing your anatomy for those kind of things. So yeah, that's what your extensor retinacular looks like. Okay, so that's those two pictures there. So your carpal tunnel and then the extensor retinacular and all the tunnels that are associated with that particular area as well. Okay, we've also got a lump of fascia in the forearm, in the palm. Okay, so the palmar fascia around this area here is again, it's quite significant. The reason why I put it in there, well, it's connective tissue anatomy, but also there are some conditions that you can have that affect the palmar aponeurosis or palmar fascia, whatever you want to call it. And so this is it. It's an expanded tendon of the muscle called palmaris longus, and we'll talk about that in a second. It helps to shape the palm and creates ridges which help improve grip. But what it also does is it provides a covering for all of the tendons, nerves, blood supply underneath the fascia. So it forms a protective layer over the top as well. So it's the kind of thickened connective tissue. It's a bit like a very small version of the thoracolumbar fascia in the lower back. Yeah, it's that kind of look. Okay, so what we've got here, I don't know whether you can see this contracture just here. This is called a Dupuytren's contracture. Let me just spell that for you, just in case you've never heard of it before. There you go. So that's how you spell it. It's called Dupuytren's. It's a connective tissue disorder. It is. You can get it in the feet as well. So you can have a Lederhosen, call it a Lederhosen disease, I think it is. But it's exactly the same. But it affects the plantar fascia rather than obviously the hand, and you'll get a claw-like presentation, and it usually affects the ring finger and the little finger first. And it's basically just a thickening of that fascia. Oh, there we go. Perfect. So Penny has just had the operation to improve Dupuytren's and now have fingers that can extend fully. Perfect. Yeah, so one of the tests that you can do is you put your hand on a flat surface and you measure the distance from the kind of metacarpal phalangeal joint down to the surface, the flat surface, and you measure in centimeters how high it is. And then obviously once it's been treated, you should be able to then fully extend the fingers. But if you notice that someone's hand is kind of clawing, then they may need an operation for that palmar aponeurosis. Unfortunately, have it in your feet too. Yeah, it's usually the way, Penny, unfortunately. I want to say that it's hereditary. I've had I'd have to check for sure, but I've had a patient with it recently, and I'm pretty sure that their father had it, and then their brother had it as well. Yeah, I can't remember for sure, but I think there is some kind of familial link. But that's your palmar aponeurosis, and this what it looks like in real life. Here we go. So an aponeurosis is basically like a flat sheet. That's what that kind of loosely translates into. So there's your palmar fascia. And like I say, it's an extension of the palmaris longus tendon, or a continuation of that tendon. When we get to the muscles, we'll have a look at that tendon. So you can see it there covering the all of the structures underneath it. So it's continuous with the flexor retinacular and the palmaris longus, and it comes up to this area here. So this is your MCP joints, metacarpal phalangeal, so your knuckles, okay, around this area here, and all across here, which is where the palmar aponeurosis attaches into. It's called the palmar plate, all along here, and again, very similar to the foot, but instead of the palmar plate, you've got the plantar plate. Okay, so it's where the what's it called? Fascia at the bottom of your foot. I can't remember the blooming name of it. But so it's where plantar fascia, of course. So it's where your plantar fascia attaches into like the knuckles of your toes. So it's exactly the same kind of setup as this. And the plantar plate, you can get injuries to the plantar plate as you can get injuries to this area of the hand as well. Okay, so we've got palmar plate in the hand, plantar plate in the foot. Let's have a look. So Penny said, yeah, they say I am the starter for mine. Oh, quite young to have it. Yes, usually male dominant disease. Yeah. Cheers, Tris. Thank you. Yeah, plantar fascia. How could you forget that? So, so this is the palmar plate here, and what you'll see is these openings here and here, and that's significant for in a sec, because what we're going to have a look at is how the tendons travel from your forearm up into your fingers. Okay, and we'll see the course that they take in a second, and the connective tissue plays a really big role in their course. So yeah, protects all the nerves and tendons underneath, and kind of forms that chunky section of your palm. Yeah, cool. So that's the palmar aponeurosis. It's pretty similar to the plantar fascia. Okay, cool. Right, last bit of connective tissue before we get into some of the muscles. Now, you may or may not have heard of these, but there are some things called finger pulleys. If you treat or you do yourself climbing, then you may have heard of finger pulley injuries. Okay, so let's have a look at what they are. So these are the bones, which we should know quite well now. So we've got the metacarpal here. So that's the bone that's in your palm. Yeah, you've got your proximal phalanx, middle phalanx, distal phalanx. This will be your MCP joint, so your metacarpal phalangeal joint just here. So that's your knuckle. Okay. PIP, proximal interphalangeal joint just here. And then DIP, which is the distal interphalangeal joint just here. Yeah, I am definitely human, Becky. Yeah. It depends what time of the day I'm teaching. That's why usually 10 o'clock is usually quite good. So what have we got? We've got, see this yellow line and the green line here. Yeah. So we've got two tendons that travel on the palmar aspect, so the palm side of your fingers, all the way, well, one of them all the way to the end, one of them not quite so far. All right, so let's have a look at the names of those. We've got flexor, so it flexes. Digitorum, flexes your digits. Superficialis, okay, so that's most superficial. And if we follow that one, superficialis goes to the middle phalanx. So it doesn't go to the end of your finger. Okay, and that's significant when you're doing testing for clinical testing. And then flexor digitorum profundus, which is the yellow one. So profundus means profound, which is deep. And that yellow one goes all the way to the end. Okay, so if you have a problem with flexing the fingers and you want to differentiate, is it flexor digitorum superficialis or is it flexor digitorum profundus, the way that you can tell is by flexing the very last phalanx. Yeah, so if you try to bend that dip joint, the only muscle that can act on that dip joint is that one, which is your profundus. Yeah, so if you can't do that, yeah, so you've lost the ability to do it, then there may be an issue with your profundus muscle. Okay, yeah, that's the way to tell between the two. So what we've got, remember I was saying about the skinny jeans that are wrapping around your whole arm. You've got even skinnier jeans around your fingers. Okay, so wrapping around the finger, we've got loads of fascia, keeping everything in place, but there are thickenings in the fascia dotted all along that flexor area. Okay, so the palmar aspect of your finger. And if we have a look at the end of the metacarpal, we've got the A1 pulley just there, so just before the joint. Then the next one, A2 pulley, is on the proximal phalanx. The next one is on the pip joint, A3. Then we've got one here, A4, middle phalanx, and then one right at the end, A5. Okay, so 5 pulleys, but they're not like this in real life. They're not just separate tunnels, they're all connected, but these bits are thicker. So it's a bit like the carpal tunnel, where you've got all this fascia covering your arm, but this bit is thicker. It's exactly the same in the finger. So you've got fascia wrapping around the whole thing, and then these bands of thickness where it's tougher. Okay, so hopefully now you can see why this is maybe an issue for climbers, because if they're using their fingers to hold their body weight onto things, if the pulley, if there's something wrong with the pulley or there's too much force put through it too quickly, then it will break the pulley, and then you'll have what's called a bowstring. Okay, so if you imagine like that one ripped, then that muscle there, or the tendon, would then go from there to there, but without being kept close to the finger here. All right, so when you contract the muscle, it will stick out. Okay, so you can see it coming down because it's not close to the bone anymore. All right, so it's something that you should be able to see quite easily. Okay, perfect. Hopefully that makes sense. We're going to see these in a sec. In fact, we're going to see these now. Where are we? Here we go. So these are your finger pulleys. So there's the plantar plate, palmar plate. I've done it again. Palmar plate. So we've got 2 finger flexors going up, so superficialis and profundus, which we've had a look at. So we'll add those in a second. We'll just have a look at the connective tissue for now. So this is going all the way up to your fingertip. And then there it is cut there. And then there's the pulleys. So we've got a thin section and then a thick section just there. There you go. And that's them cut out. So that's what we see in the textbooks, is these little tunnels. But actually they're filled in between, but it's just less dense connective tissue in between. So these attach to the phalanges, these attach to the palmar plate. And then remember, the palmar plate also attached into the aponeurosis. So you've got some really strong connective tissue around this area. We've only got one flexor tendon in the thumb. We'll talk about that when we get to the muscles. There we go. I think that's worth seeing again. So there we go. So we've got these tunnels where your finger flexors will go. So this is MCP. This is all knuckle area, that bit there. And then now you're into the phalanges. And there we go. So you've got thick area, thin area, thick area. And the thicker areas are the pulleys. And again, if you didn't have these pulleys, then the efficiency of those tendons and the muscles would be reduced because they're of the cam effect of them. So it's just physics, basically. Levers. Okay, so there's the attachment to the palmar plate and the phalanges just underneath. And then again, just one flexor in the thumb. Cool. So if you remember, the thumb doesn't have as many phalanges. It's only got 2 rather than 3. Cool. Okay. So let's have a look at some of these. What time are we at? Cool. So I don't seem to be able to feel the thickening, but could some people, and what could it mean? So you can't really feel it. You can't really feel the thickening. You can see it on an ultrasound scan. You can see the thickness of the fascia. The time when it becomes a problem is it obviously if you see that bowstringing, usually, like I say, usually in climbers or people who have to grip a lot for their work. But also you can have a thickening of the tendon. So if the profundus or superficialis tendon is injured in some way, becomes irritated and inflamed, then if you imagine they glide through these tunnels quite easily. But if you've got a thickening of the tendon, it can't get through the tunnel. So what you tend to have then is a stuck finger. So the finger's stuck and they can move it, but it will click as they move it. And it's because the tendon, the thickened tendon, is trying to get through the pulley. Right? So that's something else that can happen as well. So yeah, so injury to the pulley or injury to the tendon itself, where it then thickens. And again, sometimes they calm down. If it's inflammation, then hopefully it will calm down. But if there's an injury and then the tendon thickens itself, then that can become a permanent issue, and then you might not be able to extend the fingers. So that they may need operation on that one as well. Okay, cool. Right. My daughter had it in one of her fingers. I think it was an index finger. It was back last year, and really inflamed. I scanned it, and there was nothing wrong with the pulley. So there wasn't a rupture of that. It was just a thickening of the tendon. And it was when one of her friends was messing around and bent her finger back by accident, and that just irritated the tendon. It had a load of inflammation. You could see the swelling, and yeah, after some time the swelling went down. But we got her a finger splint to wear at night so that it could keep the finger extended. And then it was just time, really. And we did a bit of treatment stuff on it, but it was mainly time and not aggravating it, because whenever she didn't wear the splint, it would hurt in the morning because moving around in bed, you kind of catch it. So the splint helped to protect it. So, yeah, there you go. But we called it her pregnant finger because that part of her finger there was just like, it was a big old lump. Yeah, and as a teenager, she obviously hated that. She did not want that at all. Okay, enough of my daughter's hand issues. It's all fine now. We've got long muscles of the hand. Okay, so we're going to have a look at the muscles that start up in the forearm first, and obviously they end up in the hand. And then we'll look at the intrinsic muscles of the hand as we go. And as you can imagine, there's quite a few of these. So I'm breaking them down into sections. So the first bit is the long finger flexors. So we've already been introduced to these. These are the ones that travel underneath the pulleys. So we've got flexor digitorum superficialis, flexor digitorum profundus. So superficialis is the superficial one, profundus is the deep one. Okay, so profundus, profound. So these are your finger flexors. Just move me out the way. So yeah, there we've got our thinker, deeply thinking, profound thoughts. So flexor digitorum profundus. The start point is up here on the ulna. It's quite a big muscle belly on the ulna, but then the tendon's really long. Okay, so around mid shaft of the ulna, and then it splits into 4 tendons, and then we'll come down because it's flexor digitorum. It flexes your digits rather than your pollex, okay, which is your thumb. So anything with pollucis in is to do with your thumb. Digitorum is your 4 fingers. All right, so we've got medial aspect of the coronoid process, and we've explored all of these when we looked at the bones. Superior 3/4 of the anterior and medial surfaces of the ulnar body. Basically, it attaches all up there. Okay, and then yeah, around about mid shaft of ulnar, that's then where it changes into a tendon, and then it splits into the 4. And it will go to the palmar aspect, the bases of the distal phalanx of all 4 fingers. So that's the image that we've just seen where it travels all the way to the end. Okay, so the distal phalanx. So if you wanted to test this one, that's the one where you do that to make sure that you can just move that bit of your finger. So if there's a problem with that, then we know that profundus may be implicated. Okay. Right, let's have a look at that. Just need to move a few things around. So flexors, flexor digitorum, profundus, make sure we get the right one. Here we go. So flexor digitorum profundus, the deep one. Here we go. Okay, so it's quite a chunky muscle belly, and as we said, profound means deep. So, and look at that attachment. It's a huge attachment on that ulna. Yeah, that massive footprint of the attachment, which makes sense again, because that is why we can hang off our fingertips. If the attachment was only very small, so like on the lateral epicondyle or whatever, medial epicondyle, and that was it, so it's just onto that point, you can imagine that would easily come off if you put load through it, whereas this is a really broad contact, so you can produce significant force with these muscles. So here we go, as it splits into your 4 tendons, goes underneath your carpal tunnel. Oh, is that it? Might be a bit more on the next one. Yeah, so profundus. Big attachment, anterior medial ulnar, as we were talking about before. So you can see the interosseous membrane there as well. That's pretty cool. And then as it comes along, we've got splitting into 4, 1, 2, 3, 4, and then underneath the carpal tunnel. Okay, I think we've got another video for the flexors in a sec. So let's go on to the next one. So this is superficialis. So this is the one that's most superficial. And the thing that's different with this one is the attachment on the palmar aspect, so on the palm side of the middle phalanges. So it doesn't go to the end. Yeah, so if you do that finger test, then it doesn't test that. It doesn't test superficialis. Okay, it only tests profundus. and it goes to all four fingers, independent flexion of the fingers. So it allows you to do this. Okay, but they are all joined together. So that's why you can only do like certain ranges. But when they're all bent, you can bring them all together. Some people might have a split, and they can move their fingers. So if the rest of their fingers are up, they can move that one all the way down. Yeah, but you can see, like, as soon as I start to move that one, then this one starts to come with it, and it's because they usually all attached further down. Right, let's have a look at these. Here we go. So this is superficialis. So there's the profundus, and then there's superficialis. Again, look at the footprint of that muscle. It's absolutely huge. So onto the radial head, coming all the way across and onto the ulna. So I said that, but a big old muscle. Look at the attachment there. Yeah, on the ulna, over onto the radius. So it's got a really, really broad footprint again for muscle attachment, and it will also attach onto that interosseous membrane underneath as well. So that, yeah, the median nerve and the ulnar artery both go underneath superficialis, so it's well protected as it's making its way down. And then here we go again. So we've got the split into the four underneath the carpal tunnel. And now you can see them both together. I think it's on this one. So we've got a synovial sheath, and that's what gets irritated with the tendon. So the synovial sheath can get inflamed. So you got your profundus and superficialis split, and then they'll carry on. Here we go. So under your MCP joint. So this is that palmar plate that we looked at before, and now you can see the two tendons laying on top of each other. So there goes superficialis, and it splits into two, and then profundus is in the middle. There's superficialis there. So that's the one that goes to the middle phalanx, and then profundus. So there's the attachment there, and then profundus will go all the way to the end. There it is there. See it in the middle? So superficialis both sides, and then profundus in the middle, and then that goes all the way then to the tip of your phalanges. That was pretty cool. Let's have a look at that one again. Okay, so massive footprint again. Okay, so you've got a bit of an opening there for the artery and the nerve as they make their way down to the hand. Then we've got the split where you can see the tendons start to come off of that massive muscle. Carpal tunnel, so that's your flexor retinacular that we were looking at earlier. And then you can see the two tendons together there. So yeah, if you get an irritation of that tendon sheath, you might have heard it in somewhere else. There's a condition called de Quervain's tenosynovitis, and it's an inflammation of the tendon in the thumb. Okay, so around this area here. But you can obviously get tenosynovitis anywhere. So if the synovial sheath becomes inflamed, and those tendons which are wrapped in the synovial sheath have to pass through the pulleys, but there's inflammation in the sheath, which then expands the size of the tendon, it can't get through the tunnel, so it gets stuck. And that's when you get that, you get to a certain point of extension, and then you kind of have to push your finger through and it will click, or sometimes like bump through, and that can be quite sore. Sometimes it's not. So we've got profundus tendons and superficialis coming through. Lumbrical muscles, we'll talk about those when we get to the intrinsic muscles of the hand. So lumbricals have now gone. There's your palmar plate. So that's your knuckle line along there. And then there's the opening there for the tendons to pass through. So now the pulleys have been taken off. Superficialis splits. And profundus is in the middle. So that's just superficialis there. They've taken profundus out, and then that attaches on either side of the middle phalanx, and then profundus in the middle, all the way through, and then that goes to your fingertip. Okay, so again, another kind of reason why I think when we start doing things like clinical testing, and looking at the movements people have got in any part of their body really, and trying to work out where a problem might be, knowing where the attachment points are for the muscles is really important. There's been a bit of a narrative over the last few years where in sports therapy, sports massage, you don't really need to know your anatomy, and I think for manual therapy treatment it's probably true. It doesn't really matter knowing which muscles you're on because of the neurological effects of the treatment rather than the old school kind of mechanical effects that we think we used to have. But for injury and movement kind of clinical reasoning, it's really, really important to have a good understanding of where things go and where they pass through, what their jobs are, because then you can test things. And when I studied osteopathy, we didn't learn the names of the tests. So like Apley's or I don't know, well, one of the tests for the shoulder, whatever it is. We didn't really know, and the tutors didn't really know the names of the tests. But what they did do is they knew the anatomy really well. So if they wanted to test a structure, they knew where it went, and then they could put some strain through that structure to test the integrity of it. And it would be Apley's, but they just didn't know the name of the test. They just knew the anatomy so well. So it's I think it's really important when you're doing things like that. Cool. I think that will do us for a day. Where are we? Yeah, 40 minutes. Hopefully that was all good. Just get rid of that. So we're started on the muscles of the hand and the wrist, and we've got quite a few more to go. So we've looked at the finger flexors today. We'll start to build on that next week. And for those of you that are not in the UK, we have another public holiday. I think it's the 26th of May, which is the Monday. So we've got a couple of sessions and then another public holiday. So apologies if you're watching from abroad. We've got a question by the looks. Let's have a look. Slightly off topic. I have a client with a very triangular neck, bowstring like. It's normal for him. Always makes me wonder if there's a similar issue in the neck and indeed anywhere. If you want to send me, if they're okay with it, send me a picture. I can have a look at that. No probs. Rahul, you're welcome. No problem. David, thank you for joining us this morning. First one. Welcome to the team. Right, I will see you next Monday, 10 o'clock. See you then.